I'm happy to be here with you all today because we really appreciate the opportunity to have someone from Jefferson here speaking about liver-directed treatments, because this is what we do every day. As many of you know, we're a national referral center for patients with this very rare disease. 2/3 of patients who we're currently treating live outside of what would be our accepted catchment area of Pennsylvania, New Jersey, and Delaware. To the best of our knowledge, we're the only institution in the country with a weekly multidisciplinary conference dedicated solely to this disease, with medical oncology, interventional radiology, a body MRI specialist, radiation oncologist as needed. To the best of our knowledge, we're the only institution in the country with a weekly multidisciplinary clinic dedicated to patients with this disease. We're performing more than 650 hepatic embolizations per year just for patients with metastatic uveal melanoma. And as many of you know, a large number of the primary tumors are treated at Wills Eye Hospital, which is the eye hospital affiliated with Jefferson. As Karen Gonzalez noted, this may be an orphan disease, but this has found a home at Jefferson. There are 3 interventional radiologists, Karen Gonzalez and Robert Adamo, who work with Takami Sato from medical oncology, and Marlena Orloff, who spoke to this group last year. She joined our team maybe 3 years ago, maybe 4. Time is fleeting. Ronnie Ane works with us for patients requiring radiation oncology. But this is really the epitome of a team effort. I mean, it's not just physicians, nurses, nurse practitioners for when patients are for inpatients, interventional radiology PAs, research coordinators, and of course, Renee Zielinski right at the center of it all, who keeps us all in line. So, as you know, the liver is the predominant organ of involvement in most of patients with metastases. It tends to be the first organ. In half of patients, it ends up being the only manifestation of the disease. Other sites of metastases that can develop: lungs, bone, brain, tissues under the skin, nodules developing in the belly, but those sites tend not to have much clinical significance. And the clinical course of patients with metastases is generally determined by progression of the disease in the liver. This is very different from skin melanoma in how it spreads. And unfortunately, improved treatment of the primary tumor in the eye has not resulted in prolonged survival. Realistically, tiny, tiny tumor cells have broken off probably before the eye tumor has even been diagnosed and spread through the bloodstream, and then just stay dormant in the body for an undetermined period of time. Unlike skin melanoma, there's no effective systemic chemotherapy regimen for this disease. Immune checkpoint blockade therapy, ipilimumab, Pembro, has a poor response rate, high complications, no BRAF mutation with this disease. There's no proven adjuvant therapy to try to prevent or delay the onset of metastases. There's a study going on at Jefferson looking at Sutent and valproic acid. There will likely be one coming for using GP100 from Immunocore. So since the clinical course of most patients with this disease is based on status of disease in the liver, that's why we focus on doing something to treat the liver tumors, since there's no effective systemic therapy. Surgery is rarely effective because most patients have multiple tumors. We've also seen that if a liver metastasis potentially appropriate for cutting out with surgery occurs within 5 years of the primary eye tumor, some people say 4 years, but be that as it may, that if the liver met occurs too soon after the primary eye tumor, going through a big surgery procedure is apt to merely result in more tumors showing up elsewhere in the residual liver. And You don't want to unnecessarily cut out normal liver because you need as much good liver as possible. Ablation, I'll discuss a little bit near the end. Rarely useful if there are multiple tumors, but we've had a number of successes in patients who, for whatever reason, just develop one tumor, and that can be treated with ablation. This is an example of a patient who many years ago was scheduled to undergo resection of what was thought to be a primary liver metastases, and the little black dots represent metastases. Todd, would you be able to drop the lights again, because we're going to be coming up on some images. Thank you. So embolization means putting something in a blood vessel to block it off. It can be temporary, it can be permanent. That's the definition of embolization. So we're going to discuss several different liver-directed therapies. Immunoembolization means blocking off the blood vessel and putting an immune stimulant in. Radioactive microspheres are injecting tiny radioactive coated beads into the liver. Chemoembolization is blocking off the blood vessel and adding chemotherapy. I won't be discussing photomustine. That's a chemotherapy agent available in Europe. There have been some trials going on. It was something for which there was a lot of hope 10 years ago. Not really sure that that has panned out well. Isolated hepatic perfusion is the older surgical version of the percutaneous hepatic perfusion. Some of you may know that as Delcath. I'll be discussing that later and just showing a nice example of an ablation. So the purpose of this slide is not to memorize all the numbers, but just to kind of add some perspective. So this is a table of published papers looking at chemoembolization up to a few years ago. And just kind of some of the takeaway points are, one, most of the numbers are pretty small, except for this one, which actually had 125 patients. Number 1 and number 3 are from the same institution, and they couldn't duplicate the same overall survival. And part of this is also to put these overall survivals in perspective for other treatments I'm going to be showing you through the rest of this talk. Okay? The one thing is, notice that in many of these papers, there are some groups where, you know what, some patients, their tumors did shrink, and they did have some prolonged survival. Immunoembolization was developed at Jefferson by these 3 gentlemen, and part of it was because they realized in one of those older trials that was done at Jefferson that patients who lived longer started developing tumors at other points outside of the liver. And the goal was, well, maybe if we could do some type of immune therapy from the start, we could delay the onset of those other metastases too, and try to train the body to try to fight this disease. So the rationale is that if you can kill the tumor or slow the tumor by embolization, again, cutting off the blood supply to the tumor, that would hopefully stop or slow the tumor locally. And when tumor cells die, the body doesn't like that. So the body's immune system goes looking for these dead cells and tries to learn, hey, you know what, I don't like these, let's keep an eye out for them. So what if we add an immune stimulant to that immunoembolization to try to make that response a lot more robust? Okay, so hopefully local stimulation of the immune system would, the arm of our body's immune system that kind of learns to recognize various insults, and hopefully that will help suppress tumor other places in the body, potentially creating an in situ tumor vaccine. The immunologic stimulant we use is GM-CSF, granulocyte macrophage colony stimulating factor. It has a number of positive effects on making the immune system work better in, stimulating macrophages and maturation of dendritic cells, that sort of thing. I don't want to go through the premises of a very elegant article from MIT, but this is the basis of why we chose GM-CSF, because a bunch of mice with melanoma who got GM-CSF had their tumors go away. So we've been doing immunoembolization for a while at Jefferson. The phase 1 trial started in 2000. And the point of this is to, one, is this safe to do this? And two, figure out a dose. So most of the patients in this study had uveal melanoma. One of the requirements is they all have less than half of the liver replaced by tumor. And the way we do this is patients undergo treatment of one side of the liver, then about a month later they come back to treat the other side of the liver, then about a month later repeat the imaging, see how the patient is doing, see how the tumors are doing. If everything's going well, in most cases we continue. The immunologic stimulant is mixed with an old oily contrast agent that tends to get concentrated in tumors. It's called Lipiodol. And therefore, if the tumor is taking up the Lipiodol, it's kind of gumming up tiny blood vessels in the tumor, which helps to block off the blood supply, and it delivers that immune stimulant into the tumor. We follow that with something called gel foam slurry. Gel foam is something used in surgery to pack on a bleeding site and get it to stop bleeding. If you cut it up and make a slurry, like one of those little, like city scenes that you shake it and it snows, that's kind of what it looks like. The gel foam dissolves after a week or so, but again, a temporary blocker to the artery. So of this group, median means half had more, half had less. Median means the absolute middle of a group. So median, patients had 6 procedures per patient. A third of them, the tumors actually got better. A third of them had stable disease. And of those, that third for whom the tumors got better, they were living almost 3 years. And recognize this is our first paper on this. It really is, things have even improved beyond this. But this is an example of someone who was treated with immunoembolization. This is an arteriogram, meaning putting a catheter from the artery in the leg up into the artery. This is the artery going to the liver. And you can see these big tumors at the initial treatment. When he came back 2 months later for treatment, hardly any blood flow going to them. This is a later phase. We take a whole bunch of pictures when we're injecting contrast in the arteries. A later phase, you see these dense tumors. When he comes back 2 months later, just this little rim of residual tumor activity, but substantially better. And does this happen in every patient? No, but this is an example of at least the embolization getting the process started to try to control these tumors. So looking at this first group of patients, what we saw is a demarcation based on dose, that patients at higher dosing clearly had a delay in onset of metastases elsewhere in their body, suggesting that we are making some headway in stimulating the immune system to hopefully help suppress this tumor. Comparing the higher dose immunoembolization patients to a prior group of patients who had been treated with chemoembolization where the amount of tumor was matched, what we saw is survival was longer in the immunoembolization group and also delayed onset of metastases elsewhere in the body. There really wasn't a difference between the chemoembolization group and the low-dose immunoembolization group in survival. The stabilization of the liver metastases was most likely achieved by ischemic effects, by the embolization itself, but that we were developing a systemic immune response, and that was borne out also by some of the lab tests looking at various immunologic markers. And some other points is there were some patients where the tumors continued to get smaller even after stopping the immunoembolization treatment. It sometimes can take 4 treatments, not just 2, to start having an effect on the tumors. And this becomes essentially a maintenance program because there have been some other studies that show you need repeated stimulation of the immune system to have an effect. This led to another study that was mandated to be a randomized bland embolization versus immunoembolization. So half the patients got immunoembolization, half the patients got the same embolization procedure just without the immunologic stimulant. And in this one, patients were grouped by how much tumor they had in their liver to try to be a little more helpful in giving the results. Again, it was treat one lobe of the liver, come back a month later, treat the other lobe, image a month later, and as long as everything's going okay, keep going. It took about 5 years to fully treat 52 patients on this study, and one patient is still alive from this group. And what we saw is that these patients are really well tolerated. Minimal toxicity, minimal side effects, some pain, nausea, vomiting, fevers, tends to be worse after the first 2 treatments, but really the side effects with subsequent treatments in most patients, not all, are pretty minimal. Curiously enough, this was an FDA study and it was set up with a control group. It turned out that our control group was not a control because what we learned is just by the process of embolizing patients, they have an immune response, which is not surprising, but we had to prove it. And the response was more robust in those patients who got immunoembolization, but it's hard to have a control. But as I said, our control was not a control. There was a survival benefit in patients with a 20 to 50% amount of tumor. There was a tendency toward delayed onset of other metastases, but that didn't reach statistical significance. Unexpectedly and unfortunately, the patients in the group with the smallest amount of tumors in their liver actually did worse with immunoembolization. Presumably there was a paradoxical effect on that. I'll get back to that in a moment. But just, of the whole group getting immunoembolization, overall survival almost approaching 2 years, took longer to get liver mets, but this was, metastases elsewhere in the body, but these 2 numbers were not significant, but patients with greater than 20% tumor involvement did live longer. And this study wasn't designed to show a survival benefit. It was designed to assess, hey, what kind of immune response are we getting here? And certainly the immune response was much more vigorous in patients undergoing immunoembolization. Because we were stunned, disappointed, and perplexed by patients with the small amounts of tumor who actually did worse with immunoembolization, one of our residents looked back to see a group of patients who had been treated with immunoembolization at about the same time, but for whatever reason they didn't qualify for the trial, most likely because they started out with tumors outside the liver, because one of the criteria was you could only have liver metastases, no tumor anywhere else. And what we found is it took us about 14 years to figure out what we think is the appropriate dose of GM-CSF, because when we looked at this group who had all been treated with a slightly lower dose of GM-CSF, patients with less tumor did better. So we resolved that. I talked before about Lepiodol, the oily contrast agent that we mix the immunologic stimulant in. And it tends to get taken up by the tumors. And this is a nice example of a patient with the dominant tumor right here. And after performing immunoembolization, you can see the concentration of the oily stuff in the patient's tumor and also surrounding the residual vascular portion of the tumor down there. This is a feature we lose by not being able to obtain CT scans of the abdomen after treatment. We found that realistically, we're getting pretty good information from the MRIs, but it was nice to have this correlation when we were able to. So I've been saying for a number of years that there seemed to be this group of patients who do really well with immunoembolization. And it seems, anecdotally, it was about 10 to 15% of patients. And this is one of them, because notice, this is October 2010. And he had maybe a dozen and a half little tumors like this. Fast forward 7.5 years. Okay, yeah, I mean, clearly this tumor is bigger than this tumor, but this patient has had 32, 34 immunoembolization treatments over 7.5 years. He has had repeated 6-month to 1-year treatment breaks. And I just treated him this week because this tumor has grown. Last time we restarted after a treatment break, it shrunk down 20 or 30% after 2 treatments, and he went on another break. So it is for this reason that we start many patients with limited disease with treatment using immunoembolization, because what we're finding, we want to give people the opportunity that if they're going to have a really great response to immunoembolization, that they have that opportunity because it's well tolerated and can be very effective. One of our residents is looking at this right now. He's looking at a group of 174 patients treated with immunoembolization over 9.5 years. And I asked him to look at either patients who had survival greater than 3 years or they had a treatment break. And he came back and said, Dave, everyone who had a treatment break lived at least 3 years. And of these 28 superstars, half have lived over 4 years, 20% are over 6 years, and those numbers will increase because that's why we cut his search off at 2014, because 16% of these patients are doing quite well. Unfortunately, we know that immunoembolization doesn't help everyone, and just this is someone who unfortunately the tumors grew despite immunoembolization, and we know that 20 to 30% of patients will fit into this category. And for them, we then have other therapies to offer. Okay, moving on to other liver-directed treatments. We'll start with radioactive microspheres. So, radioembolization, or using radioactive microspheres. These are tiny particles, 20 to 60 microns. Okay, a micron is a thousandth of a millimeter. So you're lining up 20 to 50 of these to make in a row to make a millimeter. They're coated in a radioactive isotope, yttrium-90, that get injected into the hepatic artery. So the radioactive particles tend to preferentially go to the tumors because they're more vascular, meaning they have more blood flow, and the hope is that the radiation will destroy the cancer. And this is the delivery system, and this thing here that looks yellowish is, for treating the right lobe of the liver, 10 to 20 million of these tiny particles about to be systematically injected into the liver. So Karin has looked at our initial experience using radioactive microspheres, and these next couple papers are all going to focus on Jefferson because basically, like immunoembolization, there aren't other experiences out there in using radioactive microspheres for the treatment of this disease that go beyond double digits in the low teens. So this was a retrospective study, and this came early in our experience with using this therapy. All patients had had other treatments before, and then they went on to progress, okay? So they went on to progress from that, whatever that other therapy was, and then they got treated with radioactive microspheres. Note that most patients had a relatively, it's stratified by the amount of tumor in the liver, and most of them had still a modest tumor burden. Median survival after treatment with radioactive microspheres, which recognize this is additive, they've already had other stuff done to them, was 10 months. Again, this is our first publication on this. And most patients, it didn't make the tumors go away, but it made them stable in over half of the group. This is a subsequent paper by one of our radiation oncology residents, just kind of expanding that same group. And she was looking at some findings on PET scans that might predict efficacy of using this therapy. But one thing that was hopeful is patients treated in this admittedly retrospective group were now living 2 years after the diagnosis of their metastases, meaning that's the median. So half the people are living longer. Karin has been spearheading a study at our institution using radioactive microspheres, using SIR spheres for treatment of this disease. Half the patients were treatment naive, meaning this is their first treatment. The other half progressed after getting immunoembolization. And she's presenting this at abstract, which means I'm not allowed to discuss the results, for which I'm very sorry. But it will be made public on May 16th. I can say that they are favorable. I'm sorry that I can't be more specific, but I don't want to get in trouble. And just an example of patients with, a patient with a number of tumors that are largely stable a year after treatment. But again, unfortunately, this doesn't help everyone. And this is a tumor that was treated with radioactive microspheres. This is the PET scan showing the incredibly active, big infiltrative tumor only 2 months later. And while I talked about the group of patients who just do phenomenally well with immunoembolization, it seems that there is likely a group of about 10 to 15% of patients with liver metastases for whom it seems that we can barely slow them down and they have very little effect and what we do has very little effect on the tumors in a very short period of time. And we have one of our other residents looking at trying to figure out how we can discriminate people who do well versus people for whom we need something better and different. Now that we're going to venture back into the chemoembolization realm, just again, putting this up as a basis of the historical standards for what we're trying to improve on. So it's reasonable to focus on the largest published series, which came from MD Anderson, where they had 125 patients, admittedly over a long period of time. The chemotherapy agent they used was cisplatin. We did not have success using cisplatin. They also included leaving a catheter in the artery afterwards and infusing chemotherapy, which probably led to a lot more complications than we typically see, including severe complications than we typically see with chemoembolization. But one of the useful things about this study is, again, rather than just older, smaller series that said we did this treatment on a dozen patients with metastatic uveal melanoma, as I showed you on our last SIR paper and as we're now doing with immunoembolization, really trying to stratify, okay, based on how much tumor there is, how are we helping patients, okay? So it is disappointing to see in their group an overall survival of only 6.7 months. And really, if you take out the patients who had less than 25% tumor burden, it's pretty disappointing in everyone else, to the point of they recommend against treatment when more than 75% of the liver is replaced with tumor. That is we do not agree with that statement based on our experience. Because again, Karin, who's been very active in this realm, looked at 50 patients who all presented with at least half of their liver replaced by tumor. So this is clearly much more advanced disease, not people with one or two tiny tumors. They were treated with a different chemotherapy agent, BCNU, at a higher level than had been used in our older study, and a quarter of patients lived at least a year. And we didn't see any difference based on, in that group, how much of the liver was replaced by tumor. This is an example of one of the patients with just huge tumor prior to starting treatment and very vascular tumor, but here she is more than a year later. And interestingly enough, the left side of her liver started growing. It's called compensatory hypertrophy. Just the liver has an ability to regenerate. It is uncommon for us to see that in the course of these treatments, but thankfully for this patient it did, and it helped preserve her liver function. This is looking at the Lipiodol uptake, as I discussed a few moments ago. Here's a very vascular tumor where at the end of the treatment you can see that Lipiodol, and therefore the Lipiodol is used as a delivery agent in this case for the chemotherapy. But then her other tumor got it treated the next month again with dense Lipiodol uptake, and the tumor became avascular. Another system we use for chemoembolization is using drug-eluting beads. These are tiny beads that marinate in chemotherapy overnight, and then once they're injected, the chemotherapy leaches out to have a more controlled delivery in the tumors. These are permanent beads. All the other embolization stuff I was talking about was temporary. Radioactive microspheres are permanent but incredibly tiny. These are bigger on the order of 100 to 300 microns, but also permanent. There has been interest in this technique in Italy there are two chemotherapy drugs that can be loaded onto the beads, irinotecan and doxorubicin. Several Italian groups have had kind of amazing success in what they describe for their observations after treatment. We frankly were not able to duplicate this. When we used this technique for a number of patients, maybe none of them were Italian, I'm not sure, but we have not had the same experience. But also, they use some unusual descriptors of evaluation, some non-standard means of evaluating their success, like necrosis and reduction of contrast enhancement, and reported that as tumors shrinking, which may well be true, but that's not an accepted way of reporting results. Another one, so we approach this differently based on our experience with a multi-institutional trial in the early part of this decade, using these tiny beads loaded with doxorubicin and then following with BCNU chemoembolization, which is something I talked about before. When we were part of that trial, the requirement of the trial was to keep giving more beads, and what we learned is you give too many beads, the arteries get beaten up, and then you can't get anything in there, and then you're not really helping much at all. So we started using this, again, based on our experience in that trial, for patients with either big tumors, a lot of tumor, or tumors that were growing rapidly, because we learned over the years that both immunoembolization and radioactive microspheres work better for smaller tumors. They're really not that effective for big tumors. So patients got these drug-eluting beads and then followed with chemoembolization. And when we sat down and looked at how patients did afterwards, we realized there was a marked dichotomy based on what the tumor looked like before starting to treat it. That patients who had discrete, for lack of a better term, balls of tumor in their liver did much better with this treatment than patients who had more ill-defined tumor in the liver. And these are big tumors. These are 12 centimeters, 8-9 centimeters average in that group. Patients with the more nodular, discrete ball tumors did much better with a much longer median survival, basically to the point of when we started looking at this data, we stopped treating infiltrative patients in this manner. There have been some others at Barnes Hospital who also kind of noticed this nodular infiltrative discrepancy in patients who they had been treating. The first group listed here is skin and eye melanoma together with the better survival. So looking at this, when we expanded the group of patients, added 7 more patients, again, the same kind of criteria, median survival of 18 months, and these are for patients with really big tumors. And of this group of 16 patients with nodular tumor, 3 of them are living 5 to 7 years after starting treatment. In the interest of time, I'm going to skip through these 2, but just as an example of, and I'm sorry, if the room were darker, you'd obviously see a huge tumor here, which shrunk substantially. This is the patient's arteriogram. Big vascular tumors initially, and 4 months later, barely any perfusion to the tumors. And this patient's alive 7 years after I did this. This is a patient of Karin's, again, the same thing. Look at these really big tumors, which are pretty much a challenge to treat, and how they shrank down, and he also had a prolonged survival. Okay, Now here we go. There may be some interest in percutaneous hepatic perfusion. And PHP is based, it is not embolization blocking off the blood vessels. This is based on three primary principles. One, isolation is blocking off the drainage from the liver. Two, infusing a high dose of chemotherapy into the liver. And then three, taking that blood out of the liver, putting it through a pump like when one is on cardiac bypass, putting it through filters, and then putting the blood back into the neck. This is an example of their double balloon catheter, and there are these little fenestrations, little holes in the catheter, such that this top balloon is between the right atrium, that part of the heart, and the inferior vena cava. This is blocking off the inferior vena cava down a little lower, and these are veins that drain the liver. So the blood flow comes like this, goes into this blocked off part of the inferior vena cava, gets sucked out here, goes down, goes through the filters, and then comes back through the neck. Obviously, there's a clinical trial going on, but we do have some insight into this procedure from a paper that was published online right after Christmas, based on the experience of the group at Moffitt in Florida and the group at Southampton in the United Kingdom. This is a retrospective look at 51 patients who were treated not on a trial, compassionate use basis. Okay. 15 patients completed the course of either 4 treatments in the UK or 6 treatments at Florida. At the time that they put this out, 7 patients were still undergoing treatment. 29 patients discontinued early. Notice that some of them due to treatment-related toxicity, a third of them due to disease progression. On the median number of treatments in the UK was 2, Florida 3. So recognize that's the number of treatments that most patients were getting. This is giving us optimism that it is probably more effective than the types of treatments I was talking about earlier in controlling the tumors. But the median overall survival was 15 months, which this is a big procedure for patients to go through. And they had a number of cardiac and other complications even in this retrospective study. The clinical trial is going on. It is randomized, meaning that half the patients get PHP, half the patients get the best alternative care as determined by that local institution. These best alternative cares can be chemoembolization, ipilimumab, pembro, or dacarbazine, which is a chemotherapy agent. Their goal is to have 120 patients in each arm. And part of the reason they need to do this is they want to show an overall survival benefit. So to do that, the FDA requires a head-to-head comparison with another treatment. Similarly, less than half the liver can be replaced by tumor. Very limited extrahepatic disease is allowed in this because they really want to focus on patients with liver problems. There are currently 35 sites recruiting worldwide, 13 are the United States. I am allowed to say that Jefferson has treated the most patients in this trial, and they are hoping that a new generation of filters to clean out the chemotherapy before putting it back will reduce the effects on the bone marrow that had been seen in their prior trial. Our bone marrow makes our red blood cells, white blood cells, platelets, and melphalan, the chemotherapy agent used in this, actually can significantly affect the function of the bone marrow. Therefore, that's why they need to filter it out before giving the blood back. Treatment on the PHP arm is treatment every 6 to 8 weeks, up to 6 cycles as long as it's working well. Their primary endpoint is survival. Is this keeping patients alive longer? Then they're also looking at, well, how's it doing at controlling the liver tumors, and then also safety and quality of life, and how effective are their filters at getting the chemo out. These are the stateside centers participating in the trial. This really kind of becomes a Cecil B. DeMille show. There are over a dozen people in the procedure room for these cases to go on. It requires, in our institution, it requires 2 interventional radiology attending physicians because we feel it requires that level of support and dedication because there's so much going on during these cases. Plus 1 of our fellows, at least 2 anesthesiologists, 1 or 2 perfusionists. They're the ones who manage the bypass pump. We have 3 nurses in the room collecting data for the trial, at least 2 or 3 interventional radiology technologists who keep the equipment going and the supplies and help us with the chemo injection, 3 research coordinators outside. So this is kind of a big deal, but we have been obviously performing a number of these procedures. Totally reasonable question. In the recent procedures we've been performing, the procedure time itself is in the 2.5 to 3.5 hour range. But recognize there's at least an hour of general anesthesia time up front and getting the patient ready, and at least a good hour of that afterwards. This is taking us at least 5 hours of procedure room time. In comparison to standard chemoembolization, immunoembolization procedures, which might be an hour, hour and 15 minutes-ish of procedure room time, meaning from the moment you wheel a patient into the room to the moment the patient is out and you start cleaning up the room. So this is a substantial time and resource commitment, but we feel it's important to be trying to help answer this question. A little bit about microwave ablation. This is placing a needle under ultrasound or CT guidance into a tumor in the liver and putting a metal probe in there and, for lack of a better term, burning the tumor and creating a small defect. We have been using this in some patients who present with just 1 tumor, and oftentimes it's 1 tumor that's been shown to be stable, and or occasionally we've had some patients, this is a patient of Karen's, who most of her tumors have been controlled by immunoembolization, except for this one was subtly growing, and Robert Adamo microwave ablated that. She's now 6 years out from when she started liver-directed treatments at Jefferson. Okay, so to try to sum up how we treat patients at Jefferson, or what treatments we recommend, because this is all customized, individualized. Presuming that resection and ablation are not appropriate, which we do consider them, but that's not most of the patients. Okay, patients with less than half their liver replaced by tumor, limited extrahepatic disease, particularly as long as the tumors aren't too big. We don't know if immunoembolization or perfusion is a better initial treatment. It is our hunch that because of those, to give the opportunity of patients with getting prolonged survival with immunoembolization, that oftentimes we start with that. One consideration with perfusion is it's just a couple procedures, and then patients can often go about a year without any subsequent procedures. And there are a number of people who, for various lifestyle reasons, choose that over a monthly maintenance plan. As tumors get bigger, we talked about the drug-eluting beads with BCNU chemoembolization, patients presenting with a large amount of tumor replacement, starting with chemoembolization, patients who progress after immunoembolization, generally either perfusion or chemoembolization if the tumors are growing rapidly. Oftentimes, there are times when we say we need to start with chemoembolization right now. And certainly, clinical trials, the PHP trial that I just talked about, I'll presume there was discussion yesterday of Immunocore GP100, a very exciting systemic drug. Good, thank you. Sarah's shaking her head, yes. And we're using GP100 in patients who either show up with very limited disease up front or patients with more extrahepatic disease once their liver disease has been controlled. Things to look at in the future, just need to stratify the descriptions of patients based on how much tumor they have. Maybe that is it nodular or infiltrative, which isn't relevant for very small tumors, but as tumors get very big. And one thing that Karin harps on is it's difficult to compare liver-directed treatments where we treat one lobe of the liver and then patient comes back a month later to have the other lobe treated, that if there's a little bit of interval growth in that other lobe, that can't be considered a failure of the treatment, but by strict criteria it is. We will probably be trying to look at trials in the future where they get an MRI, where patients get an MRI before treating the next lobe of the liver. Thank you very much.